大家欢迎大家。我来自中国 CDC。这个声音怎么这么小呀？那我希望大家能够做好准备，这样呢，我们一会儿就可以开会了。我觉得非常重要的一点呢，我们今天这部分呢是由来自8个国家的专家参加今天的会议，来给大家做介绍一下关于疫情的一个准备情况。第一个呢是来自中国香港的谭兆林先生，他呢有请谭兆林先生，大家和我一起欢迎他。谢谢。整个会议呢，都是关于这个疫情的防备规划。那对于每个国家而言，世卫组织的各个成员国要从全球流行病防备上呢做出相应的规划。我呢就是给大家介绍一下。声音太小，这个会场的声音太小，议员根本听不见。
And you can see that all of those viruses except two are avian viruses. They all infect avian species, poultry and so on. There are some infecting pig and some specifically infecting human. So these are the different numbers. They have the X types and the N types. So you have X5N1, X3N2, and so on. So this is what the description of the virus is like. So throughout history, this is there are some serological evidence that there may be there have been some infection by some form of influenza before, and the first pandemic that we are aware of is the 1918 the Spanish flu, uh, the first pandemic and really the most severe pandemic we have seen. And then followed by 1957, which is called the Asian pandemic of H2N2. First one was H1N1. We have H2N2 in 1957, and that's spread around in Asia. And then the third, then followed by 1968, the H3N2 virus, which is called the Hong Kong flu. It's first detected in Hong Kong, but then this H3N2 virus is circulating until now. Okay, it changes a lot. So until in 2009, we have the H1N1, which is what we call the swine strain, but it's not a swine strain. It's a combination of swine, human, and avian genes together. So they form this pandemic strain that started in North America and mid Africa. So now we have co-circulation of several strains. So we have the H1N1, which is still the pandemic strain, with H3N2, which was changing all along, and then you have the B viruses. Even the B viruses, you have the influenza B, which is the Yamagata and the Victoria. The Yamagata is now no longer there. So we are not detecting it anymore. So the vaccine that you are receiving now for influenza actually consists of, starting from this year, 3 different viruses, which is the H1N1, which is the 2009 pandemic strain, X3N2, which is a new strain is there, and then the B Victoria. So it's 3 viruses into one vaccine. Also, at the same time, as you also remember, also talk about the avian viruses being infecting human. Everywhere you hear that, and the latest you hear that is in H5N1 infection of cows, cattle in the United States, and now becoming human get infection. In China, you always get the X5N8, X7N9, so different types. So you can see avian viruses, when it's being presented this way, will have a risk of spreading to human. So we can see, because of all these outbreaks and all these historic events, so WHO can come out to have a guideline for national and regional planning to look at pandemic plan in 1999. Okay? So there's a very detailed description. You have phase 0, which is inter-pandemic period, preparedness level 1, 2, and 3, and then you have pandemic period with plan, phase 1, phase 2, phase 3, phase 4. And there's a lot of activities associated with each one of those steps, each one of those levels. And it's very complicated. So it never be able to attend to or resolve some of the problems that's arising. In the case of interpandemic period, will be seasonal influenza. The question comes up, and they were unable to explain it in this plan. So they have updated this plan, shortened it. We have 3 periods, 4 periods: interpandemic, pandemic alert, and then you have the pandemic itself, and then you have the post-pandemic period. So there are activities associated with this planning and description of how we will be entering certain plans, certain steps, or certain phases. So this is, again, doesn't really describe everything that's needed. Okay? And then there's always question coming up. So it's not in that description, but what are we going to do? They go back to ask. So that becomes another reason why they want to renew it. So this is 2009. So we have all these different phases now simplified. The problem is, when you have all these phases, then people start sticking things to it. Say, there is this phase, this is what needs to be done. This is, let's say, we're going to close border at this stage, or we're going to produce vaccine for this stage. We're going to have enhanced hospital services, and so on. So unfortunately, the pandemic doesn't go all over the world at the same time. So if that's the case, then people need to stage their preparedness according to what is going on in their own country. Because you say, okay, let's say Europe now, a lot of cases, but then let's say in Japan, we don't have a lot of cases, but then would they go into lockdown? So that means some would apply, some phases, application could apply some areas, but it doesn't apply to the other areas. So there's a long consideration of this, and WHO planning felt that this should be modified again. So in 2000, this is the 2009 plan. In 2017, they decided to say this is going to be an all-risk pandemic planning. So it's not just for influenza anymore. This is going to be all, this may include disasters, may include atomic bombs, it may include other things into this emergency preparedness, not just pandemic anymore. So the inter-pandemic phase, we just interpret into influenza. It will be a period between influenza pandemics, alert phase, pandemic phase, transition phase, much simpler, but also addresses multiple different risks, including not just influenza. It could be, well, applied to Ebola, applied to all the other emerging infections. Also at the same time, disasters. Okay? So all of this planning depends on risk assessment of each of the countries. So WHO will do the global risk assessment saying that there's now a pandemic going on. Okay? But then it doesn't necessarily mean that your country will have a pandemic ongoing. You have to do your own risk assessment. So how many cases are there? Are there more and more people or more severe infection? You have to do the assessment yourself, so that then you come out and declare we are now in pandemic phase. So that means each country could be in a different phase of the pandemic planning. So this will be associated with your activities that you want to do in your own countries and so on. So risk assessment becomes a very, very important step for you to provide public health safety. So this is how it's being done. This is WHO would guide us to have this national pandemic influenza risk assessment. At the multiple levels, you have at different stage what needs to be done. And you have to say, you come out and say, after this assessment that we declare that our country now is also in pandemic phase. Then there will be other different things that will come on to support or applied. For example, you can start talking about getting vaccines, getting more and more antivirals. There may be stockpiles of antiviral available that you can go and apply. They would be able to say new vaccines being produced, but then didn't go through a very whole vigorous assessment. But then can be under emergency, you can use those medicines and vaccines. Okay, so that becomes a very important part of every country's pandemic planning. Risk assessment needs to be done for each step of the way. And you can see a more simplified explanation of these steps. Okay, outbreak response and all of things that need to be done as we go along for each country separately. You don't have to say, WHO's now pandemic, I need to go and lock down my border and so on. You don't. You have to do your own assessment. So what is the impact of a severe pandemic? We all went through COVID-19, so we all understand some of the things that is being planned, but didn't apply in influenza, but we went through those as we go along. You see, this is SARS in Hong Kong. Everyone's wearing masks at that time, okay? And this is the pandemic of 1918, the first Spanish pandemic, Spanish flu, and this is COVID-19. All these social implementation of social measures, separating at least 2 meters away from the next person. But I don't understand where's the data that support that 2 meters is good enough to stop spreading, because the virus may be changing. So these are things that have to gradually change as we go along, as we understand the science of the infection. This is the 2009 outbreak of the pandemic of H1N1. You can see it started in the United States, goes through all these different countries very quickly. Okay? So the dots refer to mortality. You can see it can be spreading very quickly, and mortality can be high. And if you look at this one, this is COVID-19 infection rate as compared to influenza. As you go along looking at COVID-19, the number of people infected, the rate of infection is in COVID-19 is so much faster than flu. And also the changes appear in COVID-19 as they go along. The virus changes, the ability to spread, transmission is faster, and then you can see from here that there's a big difference between influenza and COVID-19. So this is the spread of the virus in the community. So because of the pandemic, we all suffer from this shortage of essential goods. I don't understand also in Asia why whenever we have all this emergency, the first thing that goes is toilet paper in the supermarkets. So they will be going and buy all these things and then stock up, and the shelf will be all empty. In the longer term, supply chain is being interrupted because of all these social measures being put in place. They close the borders, and there's inadequate staff to help out with all the movement of all the goods and so on. So supply chain is vulnerable, and the shortages of essential goods may occur, including food, water, fuel, medicine, and many more. And in China, their pandemic plan at that time is to, once they have discovered a number of cases in a certain area, they close down the area, okay? And then there will be supply of food, supply of medicine. It is China, but may not be happening in other countries, that they may be closing down the area, but there's no food supply, there may be no medical supply, and so on. And then hostility may break out over scarce resources, and locally available goods and stockpiles may be needed to sustain the population. So we all experienced that. We all went through all these communications, all these Facebook description, all of this in COVID-19. Restrictions of personal movement. So for my personal thing, I have a grandson. My grandson was born during the middle of the COVID, and my daughter was at the time at a business trip in Singapore, so she was stuck there. So I haven't been able to see my grandchild for 2 years, simply because there's restriction of travel. I'm sure all of you have suffered from that. Restrictions on public gathering, no funerals, no parties and other events. Okay. Schools and market may be closed. School closure is an essential part of a lot of the pandemic planning. But then closing school for 2 years has devastating effect on the education of our children. So this is now being assessed and being say, is it necessary? Do we have to do that? Later on, I can show you the WHO had come up with a guideline for school closure, for how long, what can be done, and how effective they are, and using the evidence. Okay, so this is what you will suffer when there's a pandemic going on. Economic impact. We haven't been able to collect economic impact until now for COVID-19 is still being calculated. But if you look at SARS in 2003 and avian influenza, and you can see the preliminary analysis of trade, okay, the impact on the economy of COVID-19, you can see huge effect. So that means pandemic can have a huge effect. If we don't plan well, our suffering will be a lot more. As you can see from here, this is a very old slide in the 1918 outbreak. St. Louis, a city in the United States, instituted social distancing policies as soon as they have seen cases in the area. And then in Philadelphia, they delayed that decision. So you look at the mortality rate in Philadelphia as compared to St. Louis. It's very different. You have a very sharp peak mortality in Philadelphia, but then the mortality rate being stretched out for St. Louis when there are proper planning, and you'll be able to institute slowly control measures. So WHO now has just initiated on WHO initiative on preparedness and resilience for emerging threats. So it's PRET, P-R-E-T. So this is another initiative that WHO put up. The goal is to call to action. So this country will update the preparedness plan, okay? The increased connectivity among shareholders, stakeholders, and then dedicate sustained investments now to prepare in case a pandemic comes. These are the different resources that you can get. Well, WHO has many, many, many resources. But there are a few that you'll be able to help out for pandemic planning, such as the one that we talked about here. And then the most recent come out is a guideline on social measures, taking COVID-19 as experience as a guide and finding out, trying to see what are the data, what's the evidence available for influenza. So it will be good for you to go into that document and find out whether wearing masks is going to help you, washing hands is going to help you, closing schools, closing borders, and so on and so on, okay, including vaccination. So there will be a lot of guidelines being set up. So just go to WHO, all of those will be available. But sometimes it's easier to search for WHO documents using Google than you going to the WHO website. So with that, I thank you for your attention. If you have any comments, questions, we can have it later on. Thank you.
Thanks, Dr. Jiang. I just stand here. Jiang just review the different virus of influenza and also mentioned the different phase of the pandemic preparedness. The important thing here emphasize the risk assessment because the different country area they face different situation in the pandemic period. So I also mentioned the consequence of the pandemic, especially we all remember we are suffering during the COVID-19. Thanks again, Jiang. So I like to hand over microphone to Nancy.
Thank you very much. And thanks again also, John, because you've set the scene and the tone for this meeting on the background of WHO's reasoning for the pandemic, or strategies of pandemic preparedness. We next go to the Americas, and it's my pleasure to introduce Dr. Sonia Olson, who is Associate Director for Preparedness and Response at the US CDC Influenza Division. And I believe this is an online presentation.
Hello, and thank you. Thank you for the opportunity to present at the World Influenza Conference. Today I will give you a talk on influenza pandemic preparedness in the United States. I apologize that I cannot be with you in person, but I know that your conference will be a good venue to share current work on influenza and to learn from one another. As this audience knows well, novel influenza viruses are a subtype of influenza A virus that is different from currently circulating influenza viruses among humans. Novel influenza viruses include H5, H7, and other subtypes. Also, H1 and H3 subtypes can also be considered novel if they originate from a non-human species or from a genetic reassortment between animals and human viruses. Each novel case or human infection is critical to investigate, but they rarely turn into a pandemic. Pandemics can occur when a novel influenza virus emerges in the human population and is spread efficiently between people. WHO defines pandemic preparedness as a continuous process of planning, exercising, revising, and translating into action national and subnational pandemic preparedness and response plans. Although pandemics occur infrequently, planning and preparing for a pandemic is important to ensure an effective response. Planning for and responding to a pandemic is complex, and pandemics can affect everyone in a community. Therefore, public health officials, healthcare professionals, researchers, and scientists in the United States and across the world are working together to plan and prepare for possible pandemics. In the United States, we see seasonal, novel, and pandemic influenza as interrelated and build systems for seasonal flu that can be leveraged during a response. In my talk today, I'll briefly cover three areas. First, the fundamentals of pandemic preparedness in the United States. Second, assessing and testing our preparedness state. Finally, I will touch briefly on the current example of avian influenza A H5N1 virus in cattle. The mission of CDC's Influenza Division is to advance global control and prevention of seasonal and novel influenza and improve influenza pandemic preparedness and response. Through collaboration with domestic and global partners, we do several things, including building surveillance and response capacity for influenza, monitoring and assessing influenza viruses and illness, improving influenza vaccines and other interventions, and conducting applied research to provide science-based enhancements of influenza prevention and control policies and programs. In the United States, after the COVID-19 pandemic, we helped to clarify our priorities and thought about the lessons learned from the COVID-19 pandemic. First, CDC is always in a posture of readiness, both for seasonal and novel influenza. Second, our domestic and global work to detect, treat, and prevent seasonal flu plays a dual role in furthering pandemic preparedness and response efforts. Specifically, recent experiences with COVID and avian influenza have fortified our response capabilities for pandemic flu. Third, in collaboration with our state, local, federal, and international partners, CDC maintains a comprehensive layered surveillance system that tracks when and where flu is spreading, which viruses are circulating, and the severity of illnesses that are occurring. And finally, COVID-19 provided opportunities for us to enhance systems and processes, such as vaccine effectiveness and communicating risk reduction, genetic sequencing, and our H5 response specifically. In the United States, we have several plans. At the highest level, there is the National Biodefense Strategy and Implementation Plan. This plan defines biodefense as actions to counter biological threats, reduce biological threats, and prepare for and respond to and recover from biologic incidents, whether naturally occurring, accidental, or deliberate in origin, and whether impacting human, animal, plant, or environmental health. It is broader than a federal government strategy. It is really a call to action for state, local, tribal, and territorial entities, practitioners, physicians, scientists, educators, industry, and the international community to work together to elevate biologic preparedness and response. More specific to influenza is the Pandemic Influenza Plan, which is specific to our Department of Health and Human Services. The plan was first developed in 2005 and has since been updated in 2009 and again in 2017, which is the one currently on the web. Most recently in 2023, we revised this, taking into account lessons learned from the COVID-19 pandemic. However, before publishing, we began our response to the highly pathogenic avian influenza H5N1 in dairy cattle. So we are likely to update the plan again in the near future. Finally, we have some plans at the more operational level within CDC, which help guide our work at the agency. In the current iteration of the HHS Pandemic Influenza Plan, the influenza plan is structured around these 7 domains shown here: surveillance, epi, and lab activities, scientific infrastructure and preparedness, medical countermeasures, healthcare system preparedness, community mitigation, communications and public outreach, and domestic and international response policy. I'll give you a few examples of how our new plan has incorporated lessons learned from COVID-19. Many are shown here, and I'll just highlight, for example, our need to increase gene sequencing technologies. We've done that quite widely within the United States with respect to influenza. In addition, the need for rapid diagnostics and the need to continually update plans and refine and enhance these with lessons learned. In addition to our domestic work to support local and state partners, updating CDC guidance and coordinating in the interagency arena with the US government, we also support other countries bilaterally through cooperative agreements with WHO and their 6 regional offices, our partners at the Task Force for Global Health, as well as through 35 bilateral cooperative agreements, all of which include a component of pandemic preparedness. We also support global preparedness initiatives such as WHO's Preparedness and Resilience for Emerging Threats, or PRET initiative. And we are very involved in the global influenza surveillance and response system and its expansion to include other respiratory disease. Now I will shift and discuss our work assessing and testing preparedness for H5N1 in the United States. Highly pathogenic avian influenza viruses occur mainly in birds and are especially fatal in poultry. Clade 2344b emerged in 2020 and is causing a global epizootic. This picture on the right shows state detections of HPAI in wild birds since January 2022 through May 2024. In the United States, there have been detections in all states, and over 90 million poultry have been affected. Since 2022, 26 human cases have occurred globally, 50% of which were known to be clade 2344b. During 2022, when we had so many poultry detections, we monitored people for illness and even conducted a study to assess the broader risk for symptomatic and asymptomatic infection. What we found was that over 4,000 people were exposed to birds, and we monitored these for illness. Among 3% developed some mild symptoms compatible with influenza-like illness and were tested for influenza viruses. Only one was PCR positive. In addition, in a subset of people who had antibody testing, there were no serologic positives. These data are consistent with what we know about H5 viruses, low risk to humans, and only in those with close contact to infected birds or other animals. More broadly, we have also assessed our general preparedness in the U.S. Right before the recent cattle outbreak, we conducted a survey and found that more jurisdictions had experienced monitoring persons exposed to infected animals than most jurisdictions. About 60% had also experienced testing for specimens for H5. Some places also had difficulties monitoring due to personnel or funding shortages. We also learned about PPE use and antiviral stockpiles. Bottom line, our investments in public health in capacity building at the local and state level mean that nearly all states now have the ability to respond in some capacity to high-path avian influenza. In addition, we recently explored the question of whether existing surveillance systems would pick up novel cases occurring in the community. This was done by simulating a model with different inputs, specifically using healthcare setting of outpatient, urgent care, and ED, inpatients, and ICU. Our question was, if there were cases occurring at random in the community, what was the probability these cases would be detected? Which healthcare settings might be more likely to pick up cases? And how might things change with increased severity, which might vary for H5? We found that as severity increases, the probability of detection also increases across healthcare settings due to the greater probability a case would require medical attention. For example, assuming severity equal to recent observed worldwide H5 cases, the median probability of detecting at least one case was around 90% in urgent care settings and 100% in the hospital and ICU settings. This suggests that our systems are robust, but that it's also critical that clinicians maintain high rates of testing and forwarding influenza A positive specimens from persons with pertinent exposure history to public health laboratories. My last few slides will cover the current response to H5N1 in the US in light of all that we've prepared and have just been talking about. We now know that the dairy cow illness began in early 2024. Cows showed significant decreases in milk production and quality. Initially, the impacted farms were in Texas and Kansas. These were the first reported states. On March 25th, USDA reported high-path avian influenza confirmation in cows and milk samples. Now, as of June 4th, USDA has confirmed HPAI in dairy herds on over 65 farms in 9 states. There have also been detections of high-path H5N1 in cats, wild birds, and other animals on these dairy farms. Since the outbreak in cattle was identified in March, 3 human cases of H5N1 associated with exposure to infected cattle have been detected. On April 1st, the state of Texas announced that a person had tested positive, and on May 22nd and May 30th, Michigan reported the second and third human cases of H5N1. All 3 cases were in adults working on commercial dairy farms. The cases had no relationship to each other and occurred on 3 different farms with presumed or known infected cattle. The first 2 cases reported conjunctivitis as their only symptom, and the third had mild influenza-like illness or respiratory symptoms. None were hospitalized and all have recovered. Currently, there is no indication of any human-to-human transmission in either of these cases. CDC's current risk assessment for H5N1 remains the same, which is that the risk for the general public is still low. However, this development underscores the importance of recommended precautions in people with exposure to infected or potentially infected animals in contaminated environments. CDC's existing influenza surveillance systems and laboratory infrastructure are well equipped to rapidly detect human cases of H5N1 virus samples in the US. We collect, compile, and analyze information on influenza activity year-round in collaboration with many partners. Additionally, as part of our HPAI outbreak response, we are actively reaching out and holding technical assistance calls with states that have infected herds. CDC is conducting enhanced surveillance through a number of systems, and we also have planned epidemiologic studies. As I said before, we started monitoring for persons exposed to infected poultry back in 2014 when several avian influenza viruses were circulating. We worked closely with USDA at this time and developed our joint monitoring guidance, which recommends that people are monitored after exposure for 10 days. Since the episodic in 2022, we have monitored over 9,500 people. About 350 of those have reported symptoms and have been tested. In the current outbreak, so far, there are at least 390 people being monitored. So far, states and CDC have tested at least 44 people. In addition to monitoring, we have a number of influenza systems adapted for use to assess flu in the United States. That includes case reporting. Novel flu is a reportable disease in the United States. Also, public health laboratory monitoring, which has subtype data. There is also clinical lab data from over 300 labs in the United States to monitor flu activity. In addition, we're looking at syndromic data from emergency rooms to look at flu-like illness. And finally, we've recently added wastewater data to our system. National Wastewater Surveillance System has more than 600 sites reporting flu A data to CDC. This monitoring detects but does not distinguish influenza A from other subtypes, nor can it distinguish between human and non-human sources of H5N1, including dairy cattle or runoff from infected industries. So what do we do with these data when we have an alert? This slide shows the basic process. An alert could be a detection from any one of these shown on the far left, a detection in an animal, detection in wastewater, an unusual trend in lab data, an increase in syndromic flu data from emergency rooms, or a human case. When that happens, we check all our various systems at the local level and see what the picture looks like. We also engage and talk to our partners in the state and local health who have additional information. We then also share this information interagency, and together we decide what action, if any, is needed. Coupled with these surveillance systems I just mentioned is our work to do more in-depth epidemiologic investigations to understand how the virus is being transmitted to people. The important public health questions still remaining are, is there evidence of infection with H5N1 virus in exposed populations? If we find infections, what is the spectrum of illness and rate of symptomatic and asymptomatic infections? What are the types of specific exposures on these farms and dairies? And are there any behaviors associated with human infections with H5N1 virus, or any behaviors that protect from the virus? These types of studies would include seroepidemiologic data to assess symptomatic and asymptomatic risk. Finally, I just want to mention our work on communications and outreach, which is really critical to inform the public and our partners about the response. This slide shows some examples of the work done during the current response to do outreach to clinicians through our Health Alert Network, to farm workers through tailored information on how to protect yourself, and to the general public. We update these material on our website on a regular basis. We believe a strong communication team is central to preparedness and response. In summary, what I wanted to convey is that the steps to prepare and plan are important, and this should be an iterative process so that it is continually improved based on real life experiences. For us, preparedness is part of our everyday posture for influenza, and I think that helps when events such as the current H5 outbreak in dairy cattle occur. As the current response highlights, our process does work. It's a new way, that is cattle, that this virus can infect and be spread, but we rely on decades of processes and data to help us investigate the situation and understand its potential for spread. Thank you very much for your kind attention to my talk, and I wish you a very successful meeting.
Okay, thank you very much, Sonia. Sonia Austin from the United States. He mentioned something happened in the United States right now for the avian flu influenza response. I think the main idea from her presentation, we have to respond to every individual cases influenza carefully. If we want to respond better next time next time of pandemic, we have prepared respond every individual situation, usually quickly and completely. Okay, thanks again for Sonia also. Our next speaker from the PASI. PASI, let me introduce PASI right here. PASI, he's a adjunct professor at the School of Transnational Governance with a focus on global health. He is currently Chief Executive Officer of the new Gulf Center for Disease Prevention and Control in Riyadh, Saudi Arabia. His topic, he will present the influenza pandemic preparedness planning in Middle East countries. Welcome, Pasi.
Dear colleagues, it's a great pleasure of mine to say a few words about the pandemic preparedness planning in Gulf Cooperation countries, as seen from the perspective of Gulf CDC. I'm truly disappointed not being able to be there physically with you in this leading conference and to exchange views and ideas and learn from you in these days. But unfortunately, I have pressing needs from the Gulf CDC member states, Saudi Arabia, Bahrain, Kuwait, Oman, Emirates, and Qatar, that keep me in my offices in Riyadh, Saudi Arabia today for this discussion. The Gulf Center for Disease Prevention and Control is a new regional technical agency serving the needs of public health for GCC, with the vision of being a Gulf society enjoying the highest level of health and well-being through a Gulf partnership in public health, and a mission to foster harmonization, build knowledge, and generate evidence to enable the prevention of communicable and non-communicable diseases, mitigation of public health emergencies, and promotion of healthy communities across the Gulf. We do this by aiming at 4 strategic objectives: improving the public health programs, policies, and practices in the region, developing surveillance and research both at the national and the regional level, providing for training opportunities and capability building for the member states, and finally, which is most important for this discussion today, developing approaches for responding and preparing for public health emergencies. There are specific aspects of the GCC region which emphasize the need for strong pandemic preparedness and response capacities in the region. We are a region which hosts regularly large-scale, multi-million participants mass gatherings, such as the Hajj, the largest religious gathering in the world, such as the FIFA World Cup, which was held in Qatar a year ago, and other events of similar nature. The region is very hospitable and is willing to organize various kind of events and mass gatherings here. That means also that the region is a major international business and tourism hub, and many of the airports, for example, are among the largest and most interconnected airports in the world. All the 6 GCC countries are looking towards an economically sustainable future with a broader economic base than just the petroleum production, which has been the historical source of wealth in the region. The GCC as a region is increasingly interconnected, and freedom of movements of people and goods is getting more and more easier in the region. All the 6 countries are in the middle of major health system transformation projects, which will of course have an impact and which will need the support of strong preparedness and response frameworks in the region. And also in this region, as in many other parts of the world, there is a high political priority on protecting health and well-being of the residents in the region. So in terms of public health emergencies, we have a clear role and mandate to work on this topic. We do this by supporting the member states in preventing, preparing for, responding to, and recovering from public health emergencies. This happens through facilitating joint planning and collaboration of Gulf states in regional all-hazard preparedness activities. We provide early notifications on emerging hazards and routine insights on existing threats to the region. We exchange experiences between the Gulf states in emergency response and lessons learned. And we establish strong partnerships and collaborations for regional emergency management in general. And I will go through each of those in the coming slides. On the planning aspects, in 2023, we have conducted a landscape review of the public health emergency preparedness capacities available in the GCC, reviewing 100 documents on emergency management capacity across the region, doing one-to-one consultations and focus groups with 33 individuals from the health sector in senior roles in emergency management and planning. What we found is that the GCC countries have developed or updated their national plans for pandemic preparedness and response, focusing obviously, as in other parts of the world, on influenza preparedness, particularly with the lessons learned from COVID-19. Our countries have robust global frameworks that they have been leveraging, such as the WHO's technical document on strengthening the health emergency preparedness response, WHO's PRET framework, and the global influenza strategy extending to 2030. The countries score high in assessments of core IHR core capacities required for pandemic preparedness. If you look at the results from SPAR or the joint external evaluations, and have significantly extended existing capacities during the response to the COVID-19 pandemic. And I think we're benefiting out of those strengthened aspects still in the coming years. The countries have also previously collaborated in outlining a regional approach in various kind of ways to pandemic preparedness. First of all, through an action list that was to be taken regionally to prepare for avian influenza back in 2005 when this was being discussed the first time. There is a high-level GCC pandemic preparedness and response plan that was developed during the COVID-19 pandemic through the Gulf Health Council, which is the umbrella organization that Gulf CDC works for. And finally, there is an emergency response framework which was developed through the Gulf Cooperation Council, the GCC Secretariat General. In terms of the ongoing pandemic preparedness activities, some of the key activities include participation on the negotiations for the WHO pandemic agreement, which you surely know have been extended now following the World Health Assembly. Participating in the efforts to amend the current international health regulations, which was then approved in the World Health Assembly, and developing a public health emergency preparedness plan going forward. How do they do this? As just an example, you see a framework how we think about the preparedness aspects. In order to enhance the preparedness, early detection and rapid response, we strengthen regional training and knowledge sharing as depicted in the green boxes. We develop regional public health guidelines and recommendations as depicted in the maroon boxes. And thirdly, we unlock the value of public health assets, data and infrastructure across the region. And if you look at the details, focus areas in this slide, you will also see many intersections and good alignment with the overall strategy of Gulf CDC, which I hope that highlights to you how seriously we as an organization take the emergency planning, that it is something which is core to our operational mandates and our broader strategic objectives. Who is doing this? So in addition to our efficient team here in Gulf CDC, we have a network of public health emergency experts and managers from the GCC member states who represent their countries and review, provide inputs, suggestions, and will eventually be also responsible for national level implementation of these plans. On the early notification fronts, we are already have established in the first 2 years after starting up in early 2022 a regional indicator-based surveillance, which includes as pilot diseases now influenza and COVID-19. We have weekly reporting from the countries. We provide weekly feedback through a dashboard to our member states. And we have regional event-based surveillance, which is scanning routinely more than 30,000 open sources in 8 languages to identify potential emerging threats and conduct risk assessments. We've done in the 2 years already about a dozen or so risk assessments on emerging health topics, including avian influenza as one of the latest ones. And we've developed a methodology which the GCC countries have all agreed to have a common harmonized approach on these risk assessments. Other key ongoing initiatives at the regional level include a One Health working group which we have established, aiming to produce advocacy reports of the lessons learned and the current situation of MERS-CoV during the next 6 months or so. We have a public health emergency response operations plan, which we'll embark or have embarked on right now, which over the next 12 months will provide more technical and organizational details in terms of the response aspects of the 6 countries and Gulf CDC together. And finally, we are embarking on a program of simulation exercises to test the plans, both the preparedness and the response plans, on an annual basis with our member states. Why we have been able to develop all of this so rapidly in the first 2 years of the work is really very much dependent on strong partnerships with leading institutes globally. You'll see some of them as logos in here. All of them have provided input, suggestions, tools and expertise to our work, and we are extremely grateful for this strong global public health emergency network that's able to support us. And with that, I would like to say that, as an Arabic proverb says, in public health, as we are working here in the region, within the region, but also globally, which I think your conference also is a good example of, we need combined efforts. And we say when efforts combine, hope is achieved. And I think we need much more hope for pandemic preparedness globally. We are trying to do our small bit here in the Gulf region. Thank you so much for your attention. I hope this has been informational to you. And please do be in touch with any questions and suggestions that arise from this presentation or the discussions.
Thank you very much, Professor Patterson. Yes, some excellent messages there. And of course, he's dealing with a region that has some of the largest mass gatherings in the world, the Hajj. And that's over a period of days, not like Taylor Swift drawing thousands of people for a few hours. It is now my pleasure to move on to introduce Professor Jonathan Sook, and we're going to hear a little bit about Europe. And Jonathan is based at the European Centre for Disease Prevention and Control, the so-called ECDC in Europe, in Stockholm. And he's going to update us on influenza pandemic preparedness planning in Europe. Thank you, Jonathan. This is another pre-recorded presentation.
Hi, my name is Jonathan Sook. I'm a principal expert in preparedness and response at the European Centre for Disease Prevention and Control. Together with my colleague Angeliki Melidou, who works in our respiratory disease program, we've prepared the following slides on pandemic preparedness in the EU and EEA. Very briefly, I will first introduce you to ECDC and the current European Union health governance landscape, then discuss pandemic preparedness activities at ECDC, and then go on to discuss also briefly current ECDC work on avian influenza and respiratory disease surveillance. For those of you that are not familiar with us, ECDC is based in Stockholm, Sweden. We're an agency of the European Union focused on infectious disease prevention and control. We're over 350 employees from all 27 EU member states. Our budget in 2023 was 100 million euros. We work with partners globally, and in particular those working on infectious disease control, centers for disease control, regional and international organizations, including World Health Organization, and we're very pleased to be able to speak with you today. ECDC is part of what is now called the European Health Union. This was put together in response to the COVID-19 pandemic. This framework is part of a broader ecosystem in the EU. So part of the activities that happened in the establishment of the EU Health Union were that the ECDC and also the European Medicines Agency mandates were strengthened. There was a revised regulation on serious cross-border threats to health covering EU and EEA member states. And there was also the establishment of the European Health Emergency Response Authority, which is known as HERA, and is focused on medical countermeasures. For information about the regulation, this governs a lot of the activities of ECDC and as well as our countries, in particular in relation to preparedness and pandemic preparedness. This regulation reinforces preparedness, surveillance, risk assessment, early warning and response at the EU and member state level. To strengthen the crisis preparedness framework, better coordination at the EU level is a focus, streamlining cooperation between EU countries, the European Commissions, and the EU agencies. Specific chapters of focus are chapters on prevention, preparedness, and response planning, a chapter on epidemiological surveillance, EU reference laboratories, and ad hoc monitoring of events, a chapter on early warning and response systems, and a chapter on public health emergencies at the Union level. To give you an example of what this means in ECDC and at our member state level, particular activities include that the Union itself will establish a health crisis and pandemic plan to promote effective and coordinated responses at the European Union level. Member states, that is European countries from the EU, will prepare national prevention, preparedness, and response plans, and our role at ECDC is to support the development of these plans. Countries are meant to report regularly on the prevention, preparedness, and response planning, and of course they're also adhere to the international health regulations and the annual reporting requirements there. ECDC is conducting also as part of this regulation detailed assessments of country capacities in prevention, preparedness, and response, as well as on the status of their planning. We do this now every country in the EU every 3 years. Countries also report to the EU Parliament and Council, and the Commission does as well, in the state of play and progress of the prevention, preparedness, and response planning in the Union. There's a Health Security Committee, and there are many other types of activities. Looking at the graphic to the right of this screen, this is how ECDC organizes itself. Just move my face out of the way here. Starting at the top, we work together with countries to identify, prioritize, and understand emerging risks. We plan response strategies. We do a fair amount of training and capacity building, identifying and working towards gaps that are identified. Where we have events, then of course we support outbreak response. We foster and develop methods to do after-action reviews, and we promote then revising and correction of plans and addressing capacities. Where we don't have events, we also promote and conduct simulation exercises, leading into also the revision and correcting of plans. In the middle, the gray part is perhaps the most important. We work towards promoting best practices, promoting interoperability of planning, and promoting cross-sectoral partnerships, which is really quite an important part of pandemic preparedness planning. Now we'll get into this in a little bit more detail. Everything that we're doing is based on the lessons that we learned from the COVID-19 pandemic. We've published a report on this, Lessons from the Pandemic. It came out last year, but was the result of extensive country visits, documentary analysis, and so on. Some of the main lessons that we have focused on 4 different areas: investment in the public health workforce, preparing for the next public health crisis, risk communication and community engagement, and the collection and analysis of data and evidence. To give you an example of what this might mean for ECDC and our countries, for investment in the public health workforce, we're supporting the forecasting of needs and advocacy for investments in public health workforce. We're doing capacity building work, and this might be the field epidemiology training that we're doing, specific continual professional development events, and so on. Also professional exchange, fostering linkages and networks between countries and between countries, WHO, ECDC, and other partners, for example. In relation to preparedness and response planning, we're providing guidance on generic preparedness planning as well as on pandemic preparedness planning, fostering also exchange between countries, working towards doing national level lessons learned exercises through after action reviews or testing systems through simulation exercises, promoting the evaluation and monitoring of progress in preparedness and response, conducting the assessments that I mentioned earlier of health systems and their readiness for health security events, and promoting international cooperation. For risk communication and community engagement, we're doing training, promoting social and behavioral research in preparedness planning and during response to outbreaks. This was certainly a gap that we experienced at the EU level during the COVID-19 pandemic, and so we're looking to strengthen this. There's work towards establishing a community of practice and increasing the types of communication activities that we are doing. With the collection and analysis of data and evidence, we're looking to enhance the surveillance systems that exist to make them more user-friendly and to try to promote as up-to-date and quick exchange of information as is possible. So there's been a re-engineering at a technical level of the surveillance systems that have been under development. There's a European Commission joint action on surveillance. There's work on building laboratory capacities, which of course includes sequencing and is essential for informing all of the surveillance that we're undertaking. And there's work on developing operational research protocols. I will also give you a brief overview of some of the activities that we are doing. Sorry for my moving face. To give you some examples of what we've been doing specifically based on the pandemic and where we need to be going forward. Together with our close partners, WHO Regional Office for Europe, we've hosted some workshops on pandemic preparedness planning. We have another one coming up in December this year. We did guidance on public health and social measures or non-pharmaceutical interventions based on 2 expert consultations that were held, and I'll present those in a second. We had the lessons learned process that I mentioned earlier. We're working to always build the evidence base around the effectiveness of public health measures that were implemented during the pandemic. We've had a joint workshop on respiratory virus pandemic preparedness planning. We're continuing to develop simulation exercises, after action reviews, and so on. Based on the mandate that was mentioned earlier, we're doing these preparedness assessments, which then lead to specific capacity building types of activities and priorities for individual countries. There's also the established under a mandate of the EU Health Task Force, which would support the quick European mobilization for preparedness and response missions for countries that have the need. Health security strengthening in neighboring countries is also a primary area of work that we're doing. So although our mandate is primarily focused on EU member states. We're increasingly working beyond that as part of the EU Global Health Strategy. One example is the EU Initiative on Health Security, which I'm coordinating a work package on preparedness, response, and epidemic intelligence. And we're working with what are called the southern neighborhood countries in the EU, which is all of basically North Africa and the Middle East, as well as the Eastern Neighborhood Partnership countries. So this is 14 additional countries outside of the European Union, but which we view as close partners. We also have ongoing work with Africa CDC and memorandums of understanding with many CDCs globally. The EPA 6 action listed below is also for the EU pre-accession countries, the so-called candidate countries in the Western Balkans and Turkey, and this includes public health emergency preparedness and coordination work. Cycling back very briefly to the guidance that we produced on public health and social measures, this was based on the two consultations that I mentioned. We think it's quite an important dimension for pandemic planning in general. So we came up with 5 priority areas through extensive collaboration with experts and with representatives from each of our EU member states. One was to ensure that public health and social measures are incorporated and accounted for inside health security and governance landscapes. We want to ensure that there's abilities to monitor and assess the implementation of public health and social measures when they are implemented again in the future. And of course, we don't want them to be implemented in the future, but if they need to be, then we need to be able to monitor and assess them and ensure that their implementation is proportionate to health risks. We need also to understand the broader public health and social impacts of public health and social measures to understand better the trade-offs and inform the decision-making around when they should be implemented and when they should not be. Linked to what I said earlier about the work on social and behavioral sciences, we need to work to build trust and ensure effective communication through communication engagement, through addressing misinformation and the ecosystems that produce misinformation. And we need to enhance multidisciplinary coordination and decision-making, as many of the public health and social measures are implemented or affect other sectors outside of health, and so we need to ensure that the decision-making is joined up. All of these sorts of activities have informed the way that we view pandemic planning in general. So some general principles that we're following in our work are that revised pandemic plans, as many of our member states are revising their plans right now, should be based on lessons from the COVID-19 pandemic. Of course, these plans should be in alignment with the international health regulations, but also for EU member states with the regulation on serious cross-border threats to health, which has additional provisions for countries to consider. We are clear that equity considerations and vulnerable groups need to be accounted for in pandemic preparedness plans. There should be plans for engaging and communicating with communities based on insights from the social and behavioral sciences. And pandemic preparedness plans should ensure that governance and decision-making across sectors is accounted for. So again, there should be mechanisms, for example, for coordinating on decision-making and the implementation of school closures or travel measures and so on. And so these need to be addressed and established in peacetime, because during the next pandemic and during the next health crisis, it's too difficult to implement and operationalize these arrangements in a sound and evidence-based manner. I mentioned that we work closely with the WHO Regional Office for Europe. Last year, we had a series of webinars and workshops on where countries are for pandemic preparedness planning. In general, we note that most countries are at different processes. Some are considering planning to update their plans. Some are in the middle of updating plans, and some are quite far advanced. So there are different stages, but all countries are considering and engaged in the process of looking into the revision of pandemic influenza and also respiratory disease preparedness. Revisions have focused on a few key topics. Some of them also included the effective escalation and de-escalation of measures. Again, this links to the PHSM guidance that I just mentioned. The scale and duration of the response, and that plans also account for this. You need to have much more detailed planning when responses are anticipated to go on for several months or even a couple of years. The legal aspects, we noted that many countries, at least in the EU, do not always have the legal infrastructure to implement MPI and PHSM, so they need to work together across the government to be able to establish and identify what is possible and what is not possible during a pandemic. Monitoring and evaluation, of course, there's always needs for continuous improvement. And clinical management and continuation of essential health services are also important parts of pandemic influenza and COVID-19 and respiratory disease preparedness. Support needs. Countries had noted the need for stronger cross-border collaboration and cooperation and the exchange of experience and technical information. So this is a priority area for work for both WHO and for ECDC in the region. Joint procurements, so cooperation in the purchasing and stockpiling. I mentioned the HERA agency that was established in the EU, and this is one of their areas of expertise and focus is in the medical countermeasures in the EU. Continued advocacy for evidence-based public health at higher level political fora. The point here being that during the COVID-19 pandemic, decision-making was not always transparent. Of course, there are other factors than only public health that need to be accounted for during pandemics, but we want to ensure that decision-making is based on public health principles and that this is understood and advocated for at higher levels. Technical support, so very pragmatic trainings on various matters, general technical guidance, simulation exercises, after-action reviews, and so on. And of course, countries would like to see alignment between the activities that we're doing and that our partners at WHO are doing, since we work with many of the same countries. Just to give you also a brief overview of current work on avian influenza and respiratory disease surveillance at the EU and at ECDC, there's been quite a bit of activity recently. EFSA is the European Food Safety Agency, and they are, together with us, producing an avian influenza overview, which came out in March 2024. The ECDC, EFSA, and EURL webinars on avian influenza have also been occurring. There are numerous laboratory support activities. We're looking to and doing centralized support for virus characterization for influenza viruses through a laboratory support contract. We've also worked together with EFSA on a joint mandate to produce a scientific opinion on preparedness and response measures for avian influenza, an avian influenza simulation exercise, and guidelines for One Health human avian influenza case investigations. We've also published a wide range of documents. These include recently drivers for a pandemic due to avian influenza and options for One Health mitigation measures, testing and detection of zoonotic influenza virus infections in humans in the EU EEA, and occupational safety and health measures for those exposed at work. Investigation protocol for human exposures in cases of avian influenza in the EU EEA, enhanced influenza surveillance during the interseasonal period, a survey report on laboratory capacity for molecular diagnosis and the characterization of zoonotic influenza in the EU EEA, but also the Western Balkan countries, and a country survey on measures applied to protect people exposed during outbreaks of highly pathogenic avian influenza. So as you can see, it's been really a focus area for my colleagues Angeliki and the team led by Eduardo Colsoni at ECDC on respiratory viral diseases. It's also important to note that what we're recommending here, enhanced surveillance together with genomic analysis and the sharing of sequence data, access to rapid, sustainable, and cost-effective diagnostic processes, including genomics, minimizing exposure to avian influenza through appropriate protective measures and equipment, communication and awareness raising, in particular for affected or potentially affected groups, antiviral use for post-exposure prophylaxis and treatment, and some vaccination considerations, so seasonal vaccination, vaccination against AH5 influenza, for example, for occupationally exposed individuals is one group that may be considered for this. Specific vaccination recommendations are under the remit of national authorities, however, so ECDC's guidance here is really more general and providing a ranges of options based on different contexts and situations that may exist. And of course, vaccination in combination with other protective measures. Finally, also mentioned earlier, surveillance. Together with WHO, there's the establishment of the ERVIS system. So European respiratory surveillance summaries are produced here. And you can go to this website, to ERVIS, and you can find data for EU countries or data for the whole region of Europe. It's an integrated system for respiratory virus surveillance in the EU. This includes data from sentinel systems and primary and systems, and also severe disease surveillance. ECDC published this jointly with WHO Euro, also operational considerations for respiratory virus surveillance in Europe, describing how to strengthen and design surveillance systems for respiratory diseases to fulfill different surveillance objectives. There's a link to this document here, operational considerations for respiratory virus surveillance in Europe. We work with the EU-EA Respiratory Virus Surveillance Network, and that includes a network of national influenza reference laboratories. There's regular dialogue with these groups. And the epidemiology of what's happening now on a weekly basis is updated on this website. So it's always available to go and look and see what is happening and where we are with the epidemiological situation for respiratory viral diseases in the EU and EEA. This is the last slide. I would like to thank very much the organizers for the opportunity to speak today. I hope that you are all having an excellent conference. It's a pity that we're not able to attend in person, so hopefully the next time. And although I'm not able to field questions in this manner, if there are anything that you'd like to follow up with, then I will provide my email to the organizers. I'm very happy to field questions. So thank you very much again for your attention, and we're wishing you the best conference possible. Thank you.
Okay, thank you very much for Jonathan. You talked about very detailed planning in Europe country. And the most impressive for me is you mentioned how they deal with the cross-border health threat. They're very important. Not of excellent design, like support the national planning, they report the planning regularly, and also they assess the extent of the planning. The very good thing is they reported to the EU Parliament and the committee. So I think it's a very good idea for our region when we planning our influenza pandemic plan preparedness. Okay, thank you very much. Our next speaker is Hitoshi or Shitali. He's a professor in the Department of Virology at the Tohoku University Graduate School of Medicine. His topic is about influenza pandemic preparedness planning in Japan. Welcome, Hitoshi.
Thank you very much, Dr. C, for the introduction, and I also would like to thank John Tam and the members, committee members, for inviting me to this interesting conference. And I would talk about the lessons learned in Japan from a bit different perspective. And I do believe that pandemic preparedness activities are important to be prepared the next one, but I do not think that any pandemic preparedness plan in the past did work for the COVID. And also the many, or probably the most of pandemic preparedness plan developed for H5N1 type of scenario did not work for 2009 pandemic. And what the Japanese government is doing currently is probably not enough to be prepared for the next pandemic. And so I will explain why I think in that way. And the pandemic preparedness activities started in Japan in the late 90s, especially after the H5N1 in Hong Kong. And probably it's the same in many countries. And the first pandemic action plan was developed in 2005, and it was revised actually before the 2009 pandemic. And several minor revisions were also made after 2009 pandemic. And one major development is the government developed the new act on the pandemic preparedness and the emerging diseases. But the pandemic action plan did have many sections, and I think it's about 11 chapters, including the border control measures, the medical countermeasures, and other things. But many of them, in pandemic preparedness plan, the action plan, the Japanese action plan, did not work for the COVID-19 because COVID-19 was very different. And but there are some important component of the government preparedness plan. We had this new act, which they made the government to be able to declare the state of emergency according to this act. Before 2012, the government could not declare the state of emergency. So there are some the good aspect of the government preparedness plan, but there are many issues with the government preparedness plan. And this COVID-19, I was in the WHO Western Pacific Regional Office when the SARS outbreak occurred in 2003. And so this COVID-19 is very different from any of the past influenza pandemics. And also the COVID-19 was very different from SARS in 2003. And the transmissibility is much higher than influenza, the past influenza pandemic, including Spanish flu. And there are many the asymptomatic and the mild cases, which was very different from the SARS. And the pre-symptomatic transmission is very common, and probably asymptomatic transmission also occurred for the COVID-19, which makes the disease very difficult to contain. And SARS was successfully contained within 6 months after the first recognition. But the containment is very, very difficult for the COVID-19. So I was a member of the government expert panel for COVID-19 response in Japan. And we actually they issued more than 100 recommendations to the government based on the COVID-19 data. And this is one of the very first our recommendation to the government. And we set the objective of COVID-19 response in Japan. And before COVID-19, most of the pandemic preparedness plan, including the Japanese one, only considered the early containment in a very early stage, and then mitigation. And the mitigation means just the flattening of the curve, and which did not work for the COVID-19. If we use the mitigation strategy for COVID-19, probably the huge number of people would die. And we did know this from the beginning. And the recommendation was issued, given to the government on 24th of February. And from the beginning, our objective of COVID-19 response is the suppression and to minimize the transmission as much as possible, and so that the severe cases and the deaths that can be minimized. That was the objective from the beginning. But to achieve this objective, we are not sure what we should do. And but from early the time of the pandemic, actually by mid-February, the Professor Nishiura of he's the mathematical modelers, his team had this data on the left, and most of the infected people actually did not generate any secondary transmission. And a small number of infected people generate many secondary transmission. This over-dispersion or heterogeneity of secondary transmission is one of the important characteristics of COVID-19. It's actually the same with the SARS. But based on the epidemiological characteristic, we developed the strategy called the cluster-based approach for COVID-19, which was not written in the pandemic preparedness plan, because for influenza, there's the little over dispersion and the secondary transmission. So the COVID-19 was very, very different from influenza. And we also developed this concept as early as the early March 2020. That is 3C, to minimize the cluster or the super spreading event. And because most of super spreading events, we knew that most of super spreading events occurred in certain environmental conditions, including the closed spaces and the crowded places and the close contact setting. And these 3Cs, in Japanese, sanmitsu, was widely used as a public health the message. And the government and the expert, including myself, they use this concept a lot, and which probably could contribute to the suppression of the transmission. And in early time, the China managed to contain the virus by the end of March or so, 2020. But as I mentioned, we knew that it was very difficult to contain, and we managed to suppress the transmission by implementing the different approach, including the cluster-based approach. And also, there was quite the big difference between the Western countries and the Eastern countries, the Asia-Pacific countries, in terms of number of deaths, the per population. And so this is the number of the deaths per population between the Japan and this is the number of deaths. The right-hand side is the number of deaths per population in Japan, UK, and the US. And then there's still after the Omicron, our number of deaths increased, but there's still the cumulative number of deaths per population is the smaller in Japan. And so this was published in Center for the Global Development, and there's the big difference in terms of the number of deaths per population. But in Japan, as you know, we have a the highly aging population, and the COVID that killed the many elderly people. But even with the highly aging population in Japan, the mortality impact was much smaller than the US and Europe. And so I'm now involved in the new Lancet Commission on the investment in health. And so we are now developing the report on this Lancet Commission, and for the investment of health until the 2050, and of course the pandemic preparedness and pandemic prevention, preparedness, and response (PPR) is an important component of this the report, and so we compare the excess mortality between Japan and several other countries, and as you can see, there is the big difference. And but and I also I was asked to write how Japan responded to the COVID-19 in the Nature and also the New York Times, and this was presented by several speakers yesterday. And Eric Topol is the physician scientist in the US, and he wrote many things in social media from the beginning of the COVID-19 pandemic. And by comparing the US and Japan in terms of the mortality impact of COVID-19, probably there are many factors. Like this Swiss cheese, we had the higher vaccination coverage, we had the higher the rate of masking, and also the 3Cs and others. And so this kind of approach is necessary for the pandemic. And none of pandemic preparedness plan that can address all these different aspects. And all these different aspects also depends on what we are going to have as a next pandemic. So but the current investment, this is also written in the Lancet Commission report, which is in the final stage of the review process. And the current approach of Japanese government and also the high-income country is to putting a lot of resources on the vaccine R&D. And most of Japanese government funds go to the vaccine R&D. I'm also involved in the project, but the STARDA project, they had a huge the research fund for only vaccine R&D, and some other aspects the highly neglected. And it's same with most of the G7 countries. And the G7 set this the 100 days mission, the goal, and but the other aspect they not properly addressed by the current pandemic preparedness activity in the world. But the vaccine is important. Vaccine is of course important, the component of PPR, but the vaccine is only important in the late response stage. And but we have the other aspect. This is also included in the new Lancet Commission. This figure is included in the new Lancet Commission. But there are many other aspects of PPR. The prevention, which is probably one of the important, that should be one of the important component of PPR. And so some ecological interventions should be implemented to prevent the pandemic at the human-animal interface. And the preparedness is also, as I mentioned at the beginning, the preparedness is an important component of PPR, but there are some missing items in the pandemic preparedness activities. I think Fred is talking about the role of antivirals, but there's still the many low and middle income countries do not have any stockpile of the anti-influenza the drugs. And we do have in Japan, we do have some stockpiles, but it's not so clear how to use these stockpiles in case of influenza pandemic. That there are new type of the antivirals, including Baloxavir, and which may be effective in preventing the transmission. And but how to use this kind of the new tool is not clear. And as early the response, we may be able to contain the new pandemic if the early response is done. But the early detection and the early response, probably the antivirals has some roles in such the early response as a tool to contain the virus at the source. And so all these things should be addressed in PPR, and the current Japanese government approach is probably not enough. And so the next pandemic might be very different. At least I'm quite sure that the next pandemic will be very different from COVID-19, and in many different ways. And one of the important thing is the age distribution of the fatal cases might be very different. At least in all the past influenza pandemics, the affected the children. And the COVID-19 was different, and there are not many the cases in children and not many deaths in children, but it might be different. And if the many children that develop the severe clinical illness, we might be seeing the very different type of pandemic. And we may not be able to develop the safe and effective vaccine for young children. So we need to consider many different scenarios. And so it may be difficult to develop preparedness plan to address the many different scenarios. But we have to consider the different scenario. Thank you very much.
Thanks very much. Very much for the presentation from Hitoshi. Thank you very much. We know the preparedness works, but we don't know how it's going to be in the next pandemic, how to start. So we have to be flexible, smart. Japan did very good. You saved life during COVID-19. Thanks very much. Our next speaker is my co-chair, Nance Jennings from New Zealand. He will talk about influenza pandemic preparedness planning in New Zealand and Australia. Thanks.
Thank you very much for that introduction. It's a pleasure to talk to you today. I thought I would follow a slightly different tack in terms of talking about pandemic preparedness planning in both New Zealand and Australia, and utilize the implementation of our responses to COVID-19 and some of the outcomes and key lessons from that to really to illustrate how we responded to the pandemic and what we learned from it. We've seen this curve in a number of times already, and this is the basis of every country's pandemic planning. And Hitoshi has clearly illustrated the fact that really we didn't really understand what flattening the curve is, other than buying time. Buying time for what? Well, we said, well, buying time for vaccines, and certainly with COVID, we had no idea when we were talking to the public about buying time. We couldn't answer the question what we were buying time for. But indeed, it's buying time so that we can cope. As a little bit of the background to Australia and New Zealand, what is unique about these two countries and their pandemic plans is that we're island nations with no land connections. Australia is a little bit bigger than New Zealand with 25 million people, New Zealand 5 million people. Government structures, of course, with New Zealand being a small country, we've got one centralised government and governance structure, whereas Australia is a little bit more complex. It has a federal system and multi-level governance with the states and territories governed by their premiers and making their a risk assessment to the threat. So there are substantial differences there. The health systems are very similar, both high performing with both public and private health systems. Both countries have crisis management plans. Australia, the Australian government crisis management framework, and New Zealand coordinated incident management system, the SIMS. And this is the overall umbrella structure allowing our countries to sustain responses to any emergency. So under that structure sits a number of different plans. One of for earthquakes, New Zealand, we are on the Pacific Ring of Fire, so earthquake disasters are frequent. But of course, a lot of these are related to localized incidents or regional incidents rather than the whole of the country. Both countries have pandemic plans. We started planning at the Options 1967-68 meeting in Cairns, and I have the first Australasian plan outlined on the back of an envelope that Anna Hampson and I did. And New Zealand had its first pandemic plan published at the same time as John Tam illustrated the 99 WHO pandemic plan, and Australia was shortly after. And underneath these plans range a number of smaller plans. And just to give you, this is a paper by Gillian Tan from the INSPIRE group, just showing Australia and New Zealand outcomes in terms of cumulative cases per million population and mortality. And so we're at the left-hand end there, and we did pretty well, at least up until July 2020 in terms of other countries. New Zealand's pandemic preparedness plan, and this is a structure of the 2017 revised plan. It's initially developed in '99 as a living document with the structured so it could be updated and revised on a regular basis. And of course it has common goals related to mitigating the impact, human impact, the social impact and economic impact in the countries with different phases: planning, keeping the virus out of the country, stamping it out, managing it, and then managing the after effects of it and recovering from it. And underneath that is a coordination strategy, and of course with our SIM structure, with the infectious disease, health takes over, takes the leadership, not police, but health takes the leadership and coordinates the strand. And underneath that New Zealand pandemic plan sits education department, various ministry plans for mitigation, as well as regional plans, DHB hospital plans, and so on, so it's whole of population. You'll see here we utilize the term initially of stamping it out. So you can see the linkage or with our being an agricultural nation with the veterinary plans for culling poultry. And of course this terminology was changed to elimination. So I think in contrast to what Hitoshi was saying before, New Zealand and certainly Australia had the attitude within their plans. The plan was to keep it out of the country because we were island nations, and that's one major difference. I will go through the timeline of our responses here just to illustrate some of the key mitigation strategies. And of course, really intensive in New Zealand, intensive response planning got underway in February, 24th of February in 2020, when the National Coordination Centre was established and an incident management team. And effectively at that time, a pandemic plan was activated. This was in advance. This was soon after this was after the public health emergency declared by WHO and prior to a pandemic being declared, although we had already introduced border restrictions at that stage about the same time as Australia did from certain countries. Our government adopted a precautionary approach to its response. It initially utilized the pandemic preparedness plan, as I mentioned, trying to keep the virus out. But what we'd learned from the 2009 pandemic, we had to go hard and go early if we were going to flatten the epidemic curve. There was a lot of lobbying through this period from the science community and health community that we had to keep the virus out of the country. So this is why the elimination strategy was adopted early on in our proceedings. And then following this, the further border restrictions were introduced, mandatory self-isolation of those entering the country along with economic support for those people that are out of work and what have you. Continuing on into March, you can see a drift away from the influenza pandemic plan and developed a COVID-19 protection strategy that had 4 alert levels: prepare, reduce, restrict, ending in lockdown. So this concept of shutting the country down was thought about early on. And this became a key tool of the government and enabled communication, it enabled transparency and what have you, because people could understand it. And each step level was associated with increasing restrictions and restriction of movement, introduction of pharmaceutical interventions, and, as I mentioned, economic activity. Well, here we are. And these are the non-pharmaceutical interventions introduced at each level. And level 1 with travel restrictions, communication campaigns about looking after yourself, hand washing, respiratory hygiene, isolation if you get sick, testing if symptomatic, being tested if symptomatic, and of course in the background of this was all the contact tracing and what have you that Public Health Service is doing, and of course debt relief of people. And then as the situation escalated, physical distancing being enforced, precautions particularly for the high-risk groups, so anyone over 70 was told to stay at home and move out of the health system and isolate, because the risk of the older age groups was recognised early on, restricting large gatherings. In level 3, just on the verge of lockdown, this concept of staying within your bubbles was developed in New Zealand, and I'll talk more about that. But a bubble was your close contacts, household contacts or work contacts, and you stayed within those people you regularly mixed with, and with gatherings of less than 10 people, and from everyone else you kept at least 2 meters from them. And of course telehealth and these services were introduced at that stage. And then level 4, the lockdown scenarios, and was introduced with shutting down businesses and getting people to stay at home, only going outside for short periods of exercise, venues closed, etc. And a national communication program of communicating, of getting through it together. And through this, and as I'll talk a little bit more about shortly with our leadership, what was created was a team of 5 million people. And then the next important thing, we rapidly moved from level 3 to level 4 lockdown at the end of March as the virus was spreading in New Zealand, because mathematical modelling of the data that was available at that stage clearly illustrated we couldn't cope with mitigating the epidemic. So we had to move into national lockdown to control it. And we needed to do that to protect our indigenous populations who are at similar risk as our elderly in the population. So a state of emergency was declared on March 25th, and laws changed to allow the special powers of lockdown. And then we had a period after that through to May with only 16 reported clusters of 10 or more COVID. Later on, 5 weeks, we had a period where we had eliminated the virus from New Zealand, and we moved back to lower level restrictions. Air travel with Australia was introduced, however, all arrivals into New Zealand at that stage were managed in quarantine facilities. People had to be in isolation for 14 days, and testing was continued on widely. One of the issues there, the quarantine facilities we used were hotels and used hospitality staff. And I think this is a big mistake in terms of any pandemic plans. And part of the reason for this is in our SARS response in 2003, we wanted the ability for the government to close our borders. But the Ministry of Tourism came back and said, no, we will not allow that to happen. So consequently, other than border management, none of the dealing with the consequences of keeping people or dealing with aircraft coming into the country and what have you were planned for. And this is a mistake that Australia made as well. So we had 102 days with no transmission in the country. And then in August, lockdown was reintroduced again, and mask mandates were introduced. And mask mandates are another interesting area. And this is largely because the public health community were in control of the response. And of course, with the entrenched infection control strategies in our secondary healthcare system, you only wear full PPE when there's measles or a case. And so I think there was a lot of reluctance to mandate mask wearing. Vaccine rollout in 21, about the same time as Australia. And then once the vaccine was there, we introduced a traffic light system which related to the percentage of people vaccinated, community transmission, and the restrictions that were needed to control. And then in 22, the system was dropped, and all restrictions were dropped in August 2023. All mandates were dropped. So how did we do? This is the WHO graphs of New Zealand. WHO, their cases, COVID cases up to the present time, over 2 million, with, and up to the present time, 4,145 deaths. And you can see really early on in the pandemic, we did well until the escape from quarantine of in late 21 and the subsequent spread of the Omicron viruses in New Zealand. To illustrate this, this is a paper done with a timeline of events up until May 2020. So this is through 2020 and the first cluster of infections. Showing the travel restrictions being introduced there and banning of cruise ships after Australia's experience with cruise ships and so on. And the different alert levels there are shown in the different shading, alert 1, 2, 3 and 4. 3 and 4, the 3 was enacted for a very short period of time. Imported cases in dark and import-related cases in the yellow and blue cases were locally acquired. And you can see the reduction of importation cases and contacts of those cases were reduced with the strategies at that time. I haven't talked about molecular testing, and of course this was integral to our strategy of testing, and for an elimination strategy we utilised PCR right the way through because we needed the most sensitive test. And here once again are the levels of activity, at the ramping up of testing and the increased number of tests being requested as the clinical case definitions and new knowledge about COVID and the clinical case definitions were evolved. Just moving on to Australia now, and their management plan for pandemic influenza. Most recent one was 2019, which they had updated after the H1N1 pandemic. And once again, it planned an intensive effort to reduce virus transmission, included actions to reduce virus entry into the country and contain outbreaks, and aimed at containment, providing time for the production of a matched vaccine. And once again, their Prime Minister on February the 27th activated Australia's health sector emergency response plan for novel coronavirus. So it's effectively the influenza pandemic plan with the knowledge of the spread of the virus outside Australia, and once again before WHO had declared a pandemic. Although, like New Zealand, we experienced the first cases about the same time and started to manage our borders about the same time. So that illustrates the close coordination and communication of our health systems between New Zealand and Australia. And then screening of borders, quarantine extended to travellers from Iran and then progressively to other countries. And then further on in March, the government adopted a zero COVID aggressive suppression strategy, a little later than New Zealand, to minimise transmission. They declared a human biosecurity emergency and allowing to invoke restrictions of numbers of people gathering and so on, and certainly not as intensive as New Zealand. Then March 20th, Australian borders were closed to all non-residents, and then residents having to go into quarantine, once again hotels, and stay there for 2 weeks of isolation. And about the same time, a number of the states in Australia and territories closed their borders. But once again, there's quite a bit of variation there, with some states, and particularly Western Australia, remaining closed quite late. Indeed, Western Australia was virtually another country. And social distancing rules were introduced, and non-essential activities where people had to stay at home, and restriction of outdoor activities, and effectively introduction of lockdown late in March. Digital contact tracing strategies were introduced, and then at the end of May, the virus escaped from quarantine. They had moved to a sort of a period of elimination, but then the virus escaped from a quarantine facility and spread widely in Victoria and led to a lockdown in Australia, which lasted, in Victoria it lasted for 4 months. Vaccination began the day after New Zealand, and then in the middle of 21, Australia realised that really the COVID zero strategy was not sustainable, and so they developed a national plan moving away from to live with COVID, and so lockdowns were phased out once 70% of the population were vaccinated, and then in November, along with the rest of the world, international travel resumed. So this is a similar graph to New Zealand, showing 11 million cases, confirmed cases to date, and 25,000 deaths. And you can see Australia being impacted during the first wave, and then with the virus escaping the impact of the second wave of the pandemic. Sheena Sullivan sort of led this Victorian Health Department paper looking at the response up until March, the first, 3 months, looking up to March 2021. And this, once again, addresses several phases of the pandemic shown along the top, a number of cases on the left, and the different colours show that early on they were all imported cases, and that Australia had it under control for a period, and then with the escape of the virus from quarantine facility in Australia, you can see the escalation. What is illustrated there as well are the introduction of various mitigation strategies. And it's probably easier to see on the bottom of this curve here, showing travel restrictions being introduced, and the colour darkening there as and then with lockdown, total movement reduced within the states, and other strategies was closing schools and what have you. And once again, like New Zealand, mask mandates weren't introduced until August 2020. And with regard to laboratory testing as well, like New Zealand, this shows the escalation of PCR testing in line with the different introduction of different strategies and, of course, definitions of COVID-19 as we move forward. So what are the key lessons to finish on? And I think the first lesson is understanding our geographic isolation. And both Australia and New Zealand benefited from being isolated, and we had low populations, and after elimination of COVID, we had a later start to our second outbreak. Australia was in June 2020, whereas ours was delayed to December 2020. And that gave us time to allow for, to learn from other countries. Being island nations, we were able to manage logistics and lockdowns and movement restrictions more effectively. But the impact of border closures and lockdowns were considerable. The economic impact on New Zealand, for example, and opposing such restrictions, with tourism accounting for 12.5% of our workforce and 6% of GDP, so the economic burden. But I think what we used and understood was the effects of the 1918 pandemic, and this paper showing New Zealand was responsible for introduction on the Tulune of H1N1 virus into Western Samoa, with the mortality there approaching 30%, whereas American Samoa, stone's throw away, with their quarantine strategies, the virus was not introduced to until 18 months, nearly 2 years later, with zero mortality. So marine border management was prepared. We both started pandemic planning early, and it evolved. Evolved from 1999. We gained experience as we ran national pandemic preparedness plans. New Zealand was the first country to run a national pandemic plan exercise in 2002. And we learned from, and in New Zealand we had a lot of community awareness of the 1918 pandemic and the impact on society, which we learned on. Limitations of our plans was the flexibility to deal with a different virus, and this was an issue in Australia with difference from influenza, and like with the H1N1 pandemic, we didn't plan on ICUs being overrun, and similarly the aged care sector in Australia. But pivotal was leadership, and with government leadership and Ministry of Health leadership, we were able to go hard and go early. We could have gone earlier if WHO hadn't vacillated and had been more effective in getting information out in regards declaring a state of emergency. Because what governments do is they hang back and wait for WHO to make a decision. And of course, WHO decisions are a consensus decision, and they do what is best for the countries. So I think that's something that is being addressed moving forwards. There was a willingness to be led. There was respect for science, facts and evidence, and it created a platform to build trust. Communication was also important, and creating a team of 5 million people. There was a lot of mixed media in Australia because of the structure of Australia and the state government. And just to finish off with, this bubble concept was pivotal because people understood what a bubble was, and it got the concepts of scientific advice through. So it was a crucial metaphor for New Zealand. And finally, trust. And with polls clearly showed that New Zealand, with 88% of respondents trusted their government, and 71 of Australians. So we did that well in some respects. And of course, 59% for other G7 countries. So my last slide, how did we do? And I think this says clearly how we did. In New Zealand, certainly up until July 24, we'd saved 2,500 lives. So the mortality was lower than what was expected. And similarly, to a lesser extent with Australia. However, and as we move forwards with our strategies, our excess mortality was still low and on par with that of Singapore. So thank you very much.
Thank you very much, Jenny. So the New Zealand and Australia, they have the very good plan in place before the COVID-19. So they can action and respond to the COVID-19 very quickly. Actually, they get rid of the virus many times. But the other lessons learned from COVID-19, no one is safe until everyone is safe. So it's difficult. We should work together, coordinate, do the same thing at the same time. We may get rid of the new pathogen with pandemic potential in the future. Thanks very much, Jenny. Our next speaker is Penny from Thailand. He's a professor of the Tropical Medicine, Faculty of Tropical Medicine, Mahidol University. He's working at the Department of Clinical Tropical Medicine and the Vaccine Trial Center as project chair. His topic today is about influenza pandemic population planning in Thailand. Welcome, Penny, please.
Thank you, Mr. Chairman. So today, I would like to focus my talk on the influenza pandemic preparedness for Thailand, and also would like to emphasize how Thailand has achieved in terms of local production capacity. First of all, I would like to introduce to you the EPIC data of the CRO, that is the Southeast Asian region countries. The CRO comprised of 11 countries, and just yesterday, WHO has announced that all 11 countries WHO recognized as the national influenza center. It means that all the countries have the lab diagnostic system to report to WHO. So this from Gillis, the number of the proportion of influenza illnesses cases per 1,000 population in the Southeast Asian region. As note here that the influenza case, the ILI cases really declined this year as compared to last year. This year accounting only around 28 per 1,000 outpatients of the ILI, and the positivity rate for influenza was only around 15 to 18%. The number of specimens reported last year, the majority of the strain of the subtypes reported was the H3, and however this year more so towards the H1, but somehow still H3 and the B Victoria subtypes. This is a report from Thailand. The H3 influenza subtype this year was predominantly H1N1, H3N2, and B. So from the beginning of January to 2024, 144,000 cases reported. As someone mentioned, that it's very important now that 15% occurred in a newborn to under 5, and 14% occurred in adolescents. And the result of the analysis from the Department of Medical Science, Ministry of Public Health, reported in the, this year, the majority subtype reported was H3, 43.68%, and B, 42.78%, and less for the H1 pandemic strain. Now with that, actually Thailand reported outbreak of the avian flu in the year 2005. So the first national strategic plan for prevention and control of avian influenza and preparedness started in the year 2005, and then revised in the year 2008, 2013, 2017, 2021, and now is in the drafting. So altogether, we are having the 6 plans now. So as I mentioned earlier, that the National Pandemic Preparedness Plan started in the year 2005. But however, the importance line on the second plan that focused on the setting up of a local industrial scale manufacturing plant for pandemic influenza vaccine based on international standard with the egg-based technology, and also to develop staff for industrial scale vaccine research and development process. At that time, actually, the capacity of Thailand is starting from nearly, I think, 0 to 10, something like that. Yeah. But however, with the pandemic of the H1N1 in the year 2009, Thailand was also hit hard by the H1N1 pandemic strain involving in all age groups. With that situation at that time, no domestic production of bulk influenza, no experience of egg-based technology, and have imported 2.1 million doses of seasonal influenza vaccine in the year 2010. Even though in the country we have the government pharmaceutical organization in collaboration with the Pasteur Memorial supply approximately 800,000 by formulating and filling, and the rest has to be imported. And under the Global Action Plan for the influenza vaccines that mentioned by Dr. Tam, that's a 10 years plan. At that time, with the most estimated, if the production should switch to the monovalent pandemic influenza vaccines, the world can produce only around 2,000 million doses of pandemic vaccines inactivated, containing 15 micrograms of the heme agglutinin per dose. So major approaches to increasing supply of pandemic influenza, so to develop regional and national plan for seasonal influenza vaccination program, build a new production capacity, and now it's a hot issue after the COVID. We all learned that actually every region should have its own local production capacity, because it was a delay of 1 year before all the LMIC countries have vaccines for the COVID. So, also the issue of explore formulations of influenza vaccines other than those commonly used for seasonal vaccination. So set up the local capacity, the GPO, Government Pharmaceutical Organization, has, and also with Mahidol University, have developed the clinical R&D plan by technology transfer with the assistance and support from the World Health Organization under the Global Action Plan. And first started with the egg-based technology with the live attenuated H1N1 pandemic, and then the avian H5N2, and then for the sustainability of the plant production, the GPO have decided to move into the seasonal inactivated influenza vaccine, starting from the trivalent and then tetravalent now. However, based on the current plan, now the GPO moved from the egg-based technology to the cell-based technology in collaboration with the SK Science from Korea. So why started with the live attenuated influenza vaccine? The potential advantages, of course, no downstream, high yield, with a 1/8, 20 to 50 doses of monovalent vaccine per an egg. Needle-free, induction of a broad immune response, and induction of cross-reactive immune responses. And for Thailand, we have an outbreak in the year 2005 with under the WHO plan in the year 2007, state started supporting developing countries to build up capacity to produce influenza in 6 countries. I think even China have received the technology transfer from Russian by using the live attenuated, and Vietnam, Brazil, and Thailand were selected at that time. In the year 2008, with the learning process, the staff were able to produce the first seasonal inactivated at the 2 doses or 1 each. So this, when the pandemic H1N1 started, with WHO, TPO has received sub-licensing agreement on the live attenuated influenza with WHO based on Russian technology from the St. Petersburg by Professor Larissa. And luckily, the university, Silpakorn University, happened to have a pilot plant for the critical lot. So with the agreement with the university, with the Ministry of University Affairs, the GPO produced the critical lot using the pilot plant at the University of Silpakorn. And Mahidol University is assisting in the first human trial on phase 1-2 studies. So this is a live attenuated timeline that GPO, with the collaboration of Mahidol University and Silpakorn University, with the support from the World Health Organization grant, starting with nearly 2 million, and also the Thai government grant. The egg-based monovalent was received in the year 2009. The clinical trial phase 1. Why Mahidol University? We have lots of experience in the phase 1, 2, and 3 with the full CCP compliance. So we started the phase 1-2 in the year 2010-11, and the Thai FDA has granted for the emergency use of this vaccine locally in Thailand. So at the meantime, the H5N2 seed has been also given to the GPO to produce the egg-based live attenuated H5N2. Mahidol University also performed the first time of the clinical trial phase 1 by using isolation ward. And we have admitted more than 200 participants, by serially admitted in the isolation ward, because we do not have the H5N2 in the country. So we have to conduct the phase 1-2 studies under the isolation condition. So, and in parallel, WHO also have invested in the animal challenge, efficacy animal challenge study in ferret model. So together with the result of the phase 1-2 and the efficacy challenge in ferret, Thai FDA approved H5N2 live attenuated for emergency use. So for sustainability of the plant, of the production plant, GPO has policy to move from the live attenuated to inactivated using egg-based technology, and with the help of the Japanese company Kaketsuken has provided us the personnel technical advisor to the GPO. So the GPO started with the inactivated influenza vaccines with the Mahidol University, starting phase 1-2, and then 2 and 3, and moved to the efficacy trial under the Ministry of Public Health at the field site of Nakhon Phanom along the border of Thailand and Laos border. So with the and we also have conducted the inactivated trivalent in the elderly population. With all these data, the GPO filed this for licensure, and now GPO has received the license for the inactivated trivalent influenza vaccine for use locally. So with that, you see the gap over here, that the inactivated production was, and also clinical R&D was delayed because of the COVID. And the TPO has also accommodated and changed, modified the pilot plant into the COVID production plant, COVID vaccine production plant. So Thailand also was hit hard by the COVID, especially with the fourth wave by the Delta variants of concern, and now with the Omicron. Thailand has given altogether 57 million doses. So the people of Thailand, 57 million people receiving the 1 dose, and 53 million receiving 2 doses, and 33 million receiving 3rd doses of the vaccine. So this is the burden of the COVID vaccines. Thailand has also implemented all various measures that mentioned yesterday by the WHO World Bank, and also today by Dr. Tam and various countries that you have listened earlier. So that's why I would like to focus here, that with the COVID vaccine development in Thailand, in collaboration with PATH. PATH is an organization from US, and the seed that given from the Mount Sinai and the University of Texas. So the NGV hexaproase vaccine, the Newcastle disease virus backbone from the avian not causing human, inserted with the spike of the COVID vaccines and using the egg-based technology. And we have done the phase 1-2 studies, and now the vaccine licensed as a booster dose locally recently. Now, get back to the pandemic plan. Now we are, this book is on the 5th plan that has been revised in the year 2021 to 2023. This to allow relevant agencies to participate in preparing the action plan for preparing the influenza pandemic for the future. So while the country needs a plan, and as everyone says, especially Thailand, we receive most of travelers from all over the world, and we have experience of SARS, avian flu, Ebola, MERS, continuously, and disease X or infection X in the future. So the strategy 1, strengthening society, communities, and cooperation network of all sectors, both domestically and internationally. Strategy 2, developing system performance and emergency management, developing a system of surveillance, and developing a potential of domestic medical supplies, vaccines, antivirals, diagnostic, and logistical system. It's the first time that the country are able to pull in all the ministries involved in the pandemic preparedness, and the National Committee on Emerging Infectious Disease chaired by the Deputy Prime Minister, and then involving the Minister of Public Health and Interior, Ministry of Agriculture, and private sectors, and NGOs, also including the state enterprise. That's really a pioneer because of the COVID. So 3 important categories of EID, risk and threats to Thailand, of course, importing of the emerging from abroad, and also what happened in the future. So Thailand National Strategic Plan for the EID, so with the vision that country as a whole has the capacity and well-organized managerial system timely and effectively control the EI3 through multi-sector coordination, participants, and knowledge-based management in order to reduce the risk. So six strategies in a national plan include the public health emergencies preparedness, that is effectively managerial coordinating and mitigating the preparedness to prepare and response, and the EID surveillance, prevention and control using One Health policy. Enhanced public information, risk communication is very important. Everyone care for safety, especially with the COVID. The lesson learned from the COVID, I think there are rumors, scandals on the safety of the vaccines and the risk communication with the knowledge base and involving various medical societies, associations, medical associations and academic institutes are very important to bring back the confidence and trust of the communities. So number 4, international, regional and global collaboration, multi-sectorial, I already mentioned, and with the knowledge-based management. So the success of the COVID control, number 1 is leadership, based on the knowledge management and the managerial system of the country. And Thailand actually has been appraised by World Health Organization that we have a health for all and a very good health system, that everyone have access to health system in the country. And also based on the stack-on experience with the pandemic strains that we have. And now with the current and the future action plan, again, based on the One Health WHO guidelines and the PIPS framework, and again, emphasizing and creating long-term capacity to reduce potential damage and create national security, and also framework for preparing all sectors, now emphasizing all sectors, public-private partnership, and investing on the human data, surveillance, and knowledge-based decision. So this, in order to achieve, to reduce the risk, reduce illness and deaths from influenza and any novel strains that might occur. So in conclusion, Thailand, I think we succeed in establishing the local production capacity through collaboration with the World Health Organization support under the Global Action Plan, and we have the GCP compliance clinical trial and track on experiences from influenza to COVID situation, and then improve the influenza surveillance using the digital. I have no time to talk on the digital and the IT system that have been implemented in reporting the vaccinations, the AEFI of the countries, and the action plan that we are doing and under drafting now for the year 20 up to the year 2030. So thank you very much, and thank you for your attention.
Thank you very much, Professor Puni. And clearly, you have addressed one of the issues we haven't discussed in this session, and that is of vaccine supply. And it's good, interesting that you raised that and how Thailand is trying to develop it. And of course, although we are going to talk about antivirals in this meeting, and it's my pleasure to introduce the Fred Hainan, who is the Stuart Richardson Professor Emeritus of Clinical Virology and Professor Emeritus of Medicine at the University of Virginia School of Medicine in the United States. But Fred is also a board member of ISERV, whom a UK-based organisation supporting this particular conference. And Fred is talking to us on the importance of antivirals and influenza pandemic preparedness planning. Thank you, Fred. You have an opportunity to start the meeting and now an opportunity to finish.
Well, thanks very much, Lance, and I thank John. Okay. Well, I thank you for your comments, and also thanks to John for the opportunity to speak to this topic, because I think it is really one of our most important pharmaceutical interventions in terms of the early response, especially to a new influenza outbreak. I will again show you the slide, I hope. Yes, with my conflicts of interest disclosed here. Basically, I've worked on all of the agents that are currently available in our armamentarium for a response to new influenza events. I thought it would be useful in this context to look back at what's been learned with regard to the use of different antiviral type interventions in the pandemic response. And the earliest actually were blood products. And these were used certainly in the United States and I think elsewhere in responding to the 1918 pandemic. Tom Luke put together this very nice review in the Annals of Internal Medicine, looking at studies involving hundreds of patients who actually got convalescent blood products, and there were a variety that were used. But they also collected data in these reports on controls. And there wasn't a standardization here. They had different volumes that were used and different amounts that were given on multiple days. But in aggregate, the data did suggest that there was a reduction in crude mortality, substantial, from 37 to 16%, and especially if individuals were administered these products early, within 4 days after a pneumonia diagnosis, crude mortality was reduced from 59% with delayed administration down to 19%. This has, of course, stimulated a lot of interest in the potential value of using such blood products, and there have been a number of case reports subsequently. With regard to more controlled data, we know that that the use of hyperimmune globulin in the 2009 pandemic, this is work done in Hong Kong actually, appeared to reduce mortality if it was used early after this onset of illness. And they also had a larger observational study where, again, in very sick ICU-based patients who got standard of care neuraminidase inhibitor therapy, that again, adding convalescent plasma seemed to reduce mortality. The NIH then subsequently went ahead and did studies of high titer immune plasma and hyperimmune globulin added to standard of care. In most cases, this was oseltamivir in hospitalized patients, but did not see an overall improvement in clinical outcomes in hospitalized patients with seasonal influenza A. It did seem to benefit those with seasonal influenza B, and this may be because of the relative poor effects of oseltamivir influenza B virus infections. There's also been a lot of interest in using monoclonal antibodies directed against the HA stem because they have broad protective qualities for either group 1 or group 2, in some cases both groups of hemagglutinins that are recognized across the influenza A viruses. Really, these have shown inconsistent effects in uncomplicated influenza. In the one trial that I'm familiar with that has been published in hospitalized patients, that particular monoclonal was not effective in improving clinical outcomes compared, again, to standard of care neuraminidase inhibitor therapy. And most recently, there has been a study of a specific anti-stem monoclonal for prophylaxis, and this is, again, in unimmunized individuals during seasonal influenza. It failed to meet its primary outcome of reducing uncomplicated flu illness, probably because an insufficient quantity was administered. Now, there were a number of studies done in 1968 with the Hong Kong pandemic, and I've just listed several of them here, which I think are informative. So this is our first class of antiviral drugs developed in the early 1960s, and studies done in the community in several different countries using amantadine at a relatively high dose of 100 milligrams twice a day for 20 to 30 days, was effective in reducing influenza illness and also even infection. So it actually prevented infection in with about a 50% efficacy. There was a lesser effect seen in a study done in Russia, but in general, the overall conclusion was that pre-exposure prophylaxis was effective with the adamantanes, except for this one household exposure situation where it was used for post-exposure prophylaxis for a 10-day period. But also the index cases in those families were given the drug for treatment. And I'm convinced, because we subsequently saw this in the study that we did with rimantadine, that if you use that combination of the same M2 inhibitor, the same adamantane, for both treatment and post-exposure prophylaxis, what happens is there's emergence of resistant virus quickly, that it's transmitted and causes failures of the post-exposure prophylaxis. With regard to treatment, there was at least one study done in the United States in the small numbers of patients who had uncomplicated pandemic influenza, showing that there was an antiviral effect and some symptom benefit with regard to the use of amantadine therapy. 2009, there were a large number of observational reports, as you're well aware. Really no high quality, sufficiently powered treatment studies were completed and published, to my knowledge. With regard to prevention, both post-exposure and ring prophylaxis in closed settings appeared to be effective, and there's some effort to try to use prophylaxis even in schools. But in general, containment efforts with neuraminidase inhibitor prophylaxis, again, most of this was oseltamivir, were generally not effective. However, timely treatment with oseltamivir, and again, this is based on observational reports, was associated with reduced risks of the development of pneumonia, hospitalization in higher risk patients, and death in those hospitalized due to pneumonia or acute respiratory distress. And it's notable that either some, again, ecologic observations where higher oseltamivir use at the country level was associated with lower mortality and also reduced mortality in pregnant women. And I think it's really remarkable that, for example, in Japan, there were no deaths in pregnant women during the first year of the pandemic, in part because of the aggressive use of antivirals. This is just one of the largest observational studies based on a meta-analysis of individual patient data that were collected through, I think, the PRIDE network. So they had nearly 30,000 hospitalized patients. Overall mortality was 10%. You can see that this is a large number of groups contributed to this data set. The analysis showed that compared to no antiviral therapy, neuraminidase inhibitor use, and this again was primarily oseltamivir, was associated with decreased overall mortality. You can see the adjusted odds ratio there, so it's roughly a 20% effect. Similarly, there was reduction in mortality in hospitalized pregnant women, and also in even those patients who had progressed to ICU admission. Early treatment within 2 days of symptom onset was associated with basically a halving of the mortality risk compared to no treatment. So very encouraging observational data. Another effect that was reported on, and there were several studies that looked at this, was the role of early treatment in a household setting on possible transmission of virus to contacts. Now, the virology here was incomplete, but it is shown in the red outlined areas there. There was evidence that both oral oseltamivir and inhaled zanamivir seem to be effective in this. And this is an important observation, clearly, because this is part of the mitigation potential. And modeling would indicate that, if these are valid observations, this could make a major difference in terms of the speed of virus transmission and overall impact. Now, on the sort of the concerning side, with regard to neuraminidase inhibitor monotherapy, have been observations, again, with pandemic H1N1 virus, where there is a potential for resistance emergence. And this was a cohort study, I believe from France, having 22 oseltamivir treated patients who had ARDS and persistent virus detection at 5 days or later after the initiation of therapy. And 5 of these patients, or about a quarter, had treatment emergent detection of a virus with the histidine tyrosine substitution that confers high-level oseltamivir and peramivir resistance. These second samples were generally found at a median of 8 days. And this group also had the issue of more systemic corticosteroid use. And one of the unsettled issues with regard to systemic corticosteroids is their value in influenza. Unfortunately, during the 2009 pandemic, most of the studies used high-dose steroids, which clearly can increase viral replication. There are now studies going on with much lower dose corticosteroid levels that again were substantiated for benefit in COVID-19 patients. And this wasn't just a virologic phenomenon. The patients who had the emergence of the resistant variant also had higher 28-day mortality compared to the others, quite substantial mortality. And of course, we've seen some of this same issue with regard to H5N1. This is an older study looking at 129 oseltamivir treated H5 cases, and it really illustrates the importance of timely treatment, so that mortality was still reasonably high, almost 20%, if in those treated within 2 days of symptom onset. But once you get past about 5 or 6 days of illness, especially if once respiratory failure is developed, mortality is much higher. So early intervention with influenza antivirals, even in these in a virulent virus like H5N1, can make a difference. And this is, again, monotherapy. Here also, oseltamivir resistance emergence was recognized as a problem. Menno de Jong published these data involving 8 cases in this case series. Half of these patients survived. Of the 4 who did not, 3 of them had well-documented oseltamivir resistant virus emersion. You can see this was also associated with increases in the viral loads that were detected in these patients. Another issue that I wanted to bring to your attention with regard to issues of resistance is some recent work that's been done with baloxavir. And this is not in humans, but rather in bird populations. First, there was a study showing that baloxavir and peramivir could be effective for treatment of high-path influenza in chickens. And then a follow-on 4-week study showing that it was that the doses that were effective were well tolerated in chickens over a long period of time. I just bring this to your attention because this, to me, is very concerning. I would really not want to see our antivirals for humans being used in poultry populations. The authors point out that this would maybe be used to try to save rare bird species. I think that's something that really needs to be thought about very carefully. Now, I already talked to you yesterday about the value of combination antiviral therapy in the Flagstone study, and I put on this table the frequencies of emergence of the I38T and other substitutions that confer reduced oseltamivir susceptibility. And the various outpatient studies are illustrated there. The highest frequency was about 10% in patients who had H3N2, which is a more common problem with H3N2 than H1N1 viruses, and very little issue within influenza B. But in the hospitalized study, as I mentioned, the combination of baloxavir with the neuraminidase inhibitor was associated with a much lower frequency of emergence of resistance in baloxavir. And I think that really is the way forward with regard to treatment of more seriously ill patients. Now, there have been a number of questions raised, and I just want to share some of the uncertainties with regard to what we might expect with the next pandemic and what we don't really know. Will the current dose regimens that we are using in seasonal flu be adequate for preventing infection by a novel strain? And for example, with pandemic 2009, the daily dose of oseltamivir was not adequate in immunocompromised folks. It was associated with resistance emergence. They used full treatment doses for, yes, I see that, thank you very much. Will the current monotherapy regimens be adequate for treating an infection by a novel strain? And we might expect to see higher replication levels and more protracted replication. So again, we need to think about how to address this question. And again, obviously, how rapidly and how often will resistant variants emerge in treated patients, and what will be the impact for those treated patients, but also in terms of transmission to their contacts. And this gets at this important issue of which patients will require combination antiviral therapy. I just point out that some of these questions can be answered in the current seasonal period of influenza, but we really will need new data with whatever that pandemic or novel strain is. So we have to have pre-planned, protocol-driven clinical trials in place and started right away to answer these very important questions. The obvious way to do this is to pivot from seasonal influenza trials that are ongoing, like this one, Recovery is now doing studies in hospitalized patients with seasonal influenza, and had them continue on and do it in the outbreak situation. And of course, obviously Recovery, led by Peter Horby and others, was very effective at teaching us how to optimally manage COVID-19 patients. So there have been a number of modeling studies, and I've just reviewed some of these on the next two slides that have looked at the way to use antivirals in the pandemic response. And you've already heard this notion of trying to extinguish or contain an initial nidus of a novel virus emerging as a pandemic threat. And if all sorts of things fall into place, that is theoretically possible. Feasibly, I'm not convinced, but there's been a lot of discussion about this. It is clear that combining targeted household antiviral prophylaxis and social distancing measures could also substantially lower illness attack rates and provide a mitigating effect. The antiviral therapy could play a valuable role especially in reducing virus transmission in combination with these NPIs, especially when we don't have a vaccine available, or if it is ineffective. And obviously, again, if you use combinations of antivirals, you can greatly reduce the risk of resistant variants. More recent studies would suggest that, and this is studies done in Australia and in the UK, that stockpiling NAIs is warranted. The Australian report advised liberal use, actually, in outpatients during a pandemic event. In the UK one said that this is really an insurance policy. You need to have it there just in case it's a particularly virulent virus. And there have been more recent models published that have incorporated baloxavir as well. And one from the Republic of Korea concluded that if non-pharmaceutical interventions were intensified to reduce the effective are not to that level, which is more like a seasonal level, a stockpiling covering 20% of the population would be sufficient. And another one from the UK found that baloxavir treatment was cost-effective compared to oseltamivir or no antivirals from an NHS perspective. I'm not qualified to judge the modeling efforts themselves, but there's a lot that has been published and still going on. This is work where I've collaborated with colleagues at the University of Texas in Austin, looking at modeling different kinds of antiviral strategies based on age and different use of different agents. And the aim here is to reduce the burden of disease while preventing the widespread of antiviral resistance. And part of that then is to limit baloxavir use in young children. And these models assume that with the wild type virus, the R naught will be as high as 2.5 in a pandemic event, that resistant variants will have a slight loss of fitness. That may or may not be the case, but the point is there's a very low risk then that there'll be widespread circulation of resistant variants. So I'll just summarize here. Antivirals have well-documented prophylactic and therapeutic effectiveness in pandemic and severe zoonotic influenza. Their timely use combined with non-pharmaceutical interventions could really mitigate pandemic impact in the absence of vaccines, but we'll need studies to be done early for optimization of treatment dose regimens. Antiviral resistance threats will be real, and this highlights the need for diversification of antivirals in stockpiles and also for real-time virologic surveillance data to inform the use of the drugs. And then finally, something that is obvious to all of us, you really have to have rapid access strategies if you're going to use these drugs. Time to treatment is so important, and I haven't talked about, there's a whole literature on that, but we need demonstration product, studies and pilot trials to look at some of these non-traditional management approaches, telemedicine, hotlines, test and treat in pharmacies, mobile units, drugs stockpiled at home. All of these things need to be looked at during the current period so we know how optimally to use these agents going forward in a pandemic event. So thanks for your attention.
Thank you very much, Fred, for rounding off our meeting for us. Of course, what you mentioned there are a lot of strategies that have been tested during the COVID response by different countries. But how do we pull it all together? I know we're sort of over time, but we've got the speakers here, so if you have burning questions, and I see Professor Smith in the back there who will have a question, I'm sure, about pandemic preparedness. Are there any questions from the audience? Are we better prepared after our COVID experience? John Tam, would you like to comment briefly, just to summarize what you have gained from organizing this meeting?
Well, I think for all the things that we've talked about, pandemic planning is actually the key to a lot of the activities being associated with organized in international and interagency level, and also at the same time in local country level, to make sure that they are ready just in case that a pandemic will occur. So we all say that would the pandemic occur? Yes, say that definitely we will, but the only question is when. So we have to be prepared. I asked Fred to give that talk because it's something that we never realized, that pandemic happens, and that's the time when we're screaming for vaccine, like in Thailand. But during that period of time, what's going to happen? We need to have antivirals, perhaps to reduce severity of the illness and perhaps, if possible, to limit a little bit on spread. But usually transmission-wise, you really can't control at that time. So pandemic preparedness is key to all the activity that we see. Now there's stockpiling of antivirals, and also maybe if we ever going to have a universal flu vaccine, we talk about stockpiling of universal influenza vaccine. Then comes the time of distribution. How do we distribute? How do we have access? And perhaps the model of what the Thailand were doing is to build enough capacity to make vaccines everywhere. That's going to take some time. So that hopefully in 2 years' time we see something. Thank you.
Thank you, John, for those final comments. And I think it's up to me now to thank the speakers for contributing to this meeting, thank the audience for participating, and wish you all the safe travels. And to thank my co-chair, Dr. Shi, and I would like to invite him to say thank you to the audience and give a final comment.
Thank you, everyone. Thank you for participating in this session. I think it's very important. We got a lot of useful information from our speakers. So have a good trip back home. Thank you very much. Thanks.